No, that was incredible. I've known Dr. Starnes for a long time. He was the king where I was doing fellowship, and so it's just so amazing to see this coming so far. So we're going to switch gears a little bit, talk about a different section of the aorta. More, over time in these types of meetings, you see all these like incredible things. The day-to-day, of course, is your infrarenal aortic aneurysm and how we deal with that guy. And, TREO is really special because this is a company that started out in the thoracic region and then moved to the abdominal. All the other companies abdominal and then went to thoracic. And so it's interesting now that they've come onto the market with this wonderful device, TREO, which I'll talk to you about. And what we're specifically going to be talking about is EVAR, and not kind of the fancy things. What I'm going to be talking about is just what's special about this device, and then show you my own cases. So these are not from TREO, these are my patients, and what was specific about each one that the TREO really fit for. Because, when this initially hit the market, there was a question, well, is this a niche device? We've got Gore at 50% of the market share. There's, of course, Medtronic for certain things, Cook for others, with fenestrateds. But what does TREO do? Well, what I'm here to say is that TREO really isn't a niche device. It should be really something that you can use for all infrarenal aortic aneurysms, and I'll show you a bit about why. So don't have to show this group this. Of course, you know that as time is passing, and even from the last session that we were at, endovascular is really taking over. And part of it is because there's a lot of money to be made in this area, but also part of it is that patients are living longer, we're doing better with medicine. And so they're starting to come in with no longer those apples on a stick, of course. I shouldn't even say no longer. They aren't coming with apple on a stick anymore. We're seeing these patients with issues up at the neck, but with the new devices coming out, they still could potentially be treated with infrarenal grafts. And so instead of giving you a big barrage of like, these are all the fancy bits and pieces about the TREO device, I'm going to talk to you about what do we care about as a vascular surgeon. Well, what I care about is access. Can I get this thing in a person? Is it going to make me upsize my sheets? Of course, deployment accuracy. How many pieces am I going to have to use? And if I decide to use 2 instead of 3, am I going to pay for that later on? Flexibility, obviously, of the device, and fixation. I don't want to deal with leaks. I don't want to deal with the patients coming back. I want to have a good first round hit where the patients do well. And then, of course, durability, incredibly important, not just the graft material, but also in terms of what it can do. We just had a great talk about sac regression, and that's something special that the TREO can give you. So I will give you just a few slides, if you've not heard of this device, about what it specifically does. Really, the range, you can do a neck from 20 to 36, so that's the nice range. Those of you who use TREO for the thoracic will know that it's known to have the larger sheath sizes are necessary. You have to upsize. You don't necessarily have to do that with TREO, so think about it separately. So if you're a thoracic user, it's not like this is a big giant device coming into the infrarenal portion. And the deployment is actually really quite easy. Again, if you're a thoracic user, you know that while it's wonderful deployment and accuracy, because you got that double set where you get to put it up into the thoracic aorta and then do the secondary piece, it does involve those 4 different steps. When you're doing the infrarenal aortic aneurysm repair, it's really quite simple. You just put it up, line it up, and then you just roll back the device with the gray knob, and then release the top cap, which is very, very simple. The deployment accuracy as a result is excellent. You're able to actually line up exactly. I've never had an issue at all with it, so I won't delve too much into it other than saying it's because the device really slowly flowers. So once again, if you use the thoracic device, you'll know about that, how slowly it can open. Similarly here, the TREO does the same thing. So they've taken all the good things about that and brought it into the infrarenal segment. There are clasps that keep everything kind of set at the top. I don't know if you noticed in Dr. Starnes' talk, where he was showing that beautiful twisting. The reason, of course, that's happening is because those barbs are all held together, able to do the twisting, and then ultimately, once the top cap opens up, really seals in place. So sealing, as I mentioned, super important. I've just lined up over here the different types of endoleaks and what specifically about TREO makes it special to stop allowing things like type 1As, type 2s, as we talked about, type 3s, of course, and type 4s. Really, type 1 and 2 is what I'll speak about. There is dual fixation up at the top, which really helps you with the reduction in endoleaks, and I'll show you some data in a moment. And of course, the longer device has been associated with less type 2 endoleaks, which translates to sac regression, which translates to decreased mortality. This is the fixation, just to give you a breakdown right at the top. You can see there's A and B specifically, and you can see the barb down at the bottom. So there's like one at the top, one at the bottom, like 2 hooks, and they hold it. That's the dual fixation. And then, of course, the edge of the stent that has the radial force. And here, the type 1A endoleak, this is now going out 5 years, 2.71 out of the 133 patients from their study. The longer body of the graft is unique. Again, if you're talking about Gore, of course, which a lot of people use, again, 50% of the market share. there. Gore has those short bodies, the 3 or 4. Here, you can go quite long with that main body, and then you're able to put the limbs down. So it's quite amazing. I've never really had an issue at all with getting lengths appropriate, regardless of where the bifurcation is, because there are so many options. And the longer the main body, the better your chance of having a reduction in your type 2 endoleaks. One of the things that was a concern with TREO in the beginning was, hey, what about these limbs? Are they going to have issues with thrombosis or stenosis? And actually, that's been completely handled because they actually iterated during the study to make the limbs better, and ultimately got to a point where we've got that interlock technology, so type 3 is essentially a non-issue, but also in a way that if the graft moves or flexes, you don't get that contortion in 2 points. Because you can imagine if that happened, you could twist the entire graft, resulting in thrombosis. And that does not happen with this device. Never say never, of course, but has not happened to me and has not happened in the study. And of course, once again, very, very flexible. I don't have to reiterate what Dr. Starnes showed. That's amazing. I had not seen that before, and just goes to show again about the flexibility of this device. And of course, the sac regression. So now, in the last couple of minutes, I'm going to talk to you again, real practical, you to me, vascular surgeon to vascular surgeons, about what we care about. So I'm no longer, certainly where I am, not seeing any straight up layup patients that are infrarenal aneurysms. They've all got some problem. And I'd like to be able to, I do fenestrateds where we are, but I would like to be able to use an infrarenal device if I can. So to begin with, I'm going to start out showing you an angulated neck. So it'll just take a second, but again, worth seeing. And what I'll show you is the angle, I'll show you what we did, and I'll show you the post-CT scan for this and a couple other things that we care about. So it's a bit slow, but worth seeing. And again, remember, this is all infrarenal. Yeah, I know. That's what I said too. And I am definitely a person that will, if it needs to be done open, it'll be done open. So not somebody that's going to push any major bounds of endo, but this is one of the patients that was around. I was the PI for TREO at our institution, and based on all the criteria, it met IFU for what we were able to say, okay, I'm willing to give it a try. And indeed, putting the wires up obviously helps. So it'll hopefully play. Yep, there you go, because you can see the aneurysm here. We were able to put the device up. And what I want to call your attention to is how nicely it took that angulation, which is great. The Gore has conformable, obviously, but I would never do this without the suprarenal fixation. It's my preference here to ensure that I won't have issues in the future, nor that slip that you can get, and then the sudden type 1A where they show up in the middle of the night and you have to take out the whole thing. So this patient is now a few years out. It's been durable and really had no major issue. And this is the final scan. So no, they made me a believer in terms of angulated necks. Again, no device is best for everything, but it's just good to know that, hey, this can take that type of a neck and do it on IFU. So pretty solid. So next up, one of the big issues, the thrombus-laden neck, right? Everyone's worried about toothpasting into the renals. Can I put something up there, especially if I'm doing the suprarenal fixation? That's going to make it even harder to go and do something if I do send a bunch of stuff down into the renals. So let me show you this. One of the reasons that TREO is said to be good for the thrombus-laden neck is because that slow deployment, where it doesn't just bang open, allows the thrombus to just, it's sitting there anyway. This is not going to be acute thrombus. And it can gently just hold in place everything. And so I have actually found this to be the most fun thing about the TREO graft, that I can use it in a thrombus-laden neck, infrarenal, and be very safe. You can see all that stuff. And here's the graft showing you just how it worked in that particular situation. And I can show you examples all day long about, anecdotal things, but we are actually studying this, and Dr. Stoner also is looking at these types of patients, and it's been not just me that said that, indeed, the thrombus-laden neck does do well. If you're going to put a graft in, this is a great one because of the way it deploys. All right, now, 2 pregnant aneurysms I'm going to show you. So what do I mean by that? I mean like this type of patient that has the big side And why am I showing you this? Well, forget the top now, right? We've obviously got seal. That's not an issue, though. It's a conical neck. The issue is, well, look at the way that limb comes off, the iliac comes off, right? Like, can I get into that and really seal properly? Am I going to have a big bend in that area that's going to result in thrombosis? Should just be done open and deal with it that way. Well, let me show you here. Once the Lunderquist go in and the EVAR goes in, it just really nicely put everything in the right spot. And what was the reason for that? Is because of the length of that body. I had multiple options to choose from, and I was able to get a nice long body that allowed me to get everything seated versus having a short one and then having the limbs kind of go off in whatever direction. So I was able to control the way the aneurysm eventually looked because I had that long body to choose from, and I was able to use an 80 in that particular case. And I mean, very happy with that. This one is a little bit more exciting. But same kind of concept where like it's off to the side and you have a concern about the limbs. So I wanted to show you a couple things more proximal, a couple things distal.
Looks like this one's 9 months due.
Yeah, right. Here I did it C-section, and look how good it looks. Now, the dissected one, and I'll end with this. I previously had an infected one in there, and quite honestly, I mean, if you obviously do those open, but if you get into a situation where you have to put something in an infected, gore is the way to go. That thing slides out nicely when you do need to ultimately fix it. So I wouldn't suggest putting suprarenal fixation in that. But here's a dissected aneurysm, got a little bit of a long, and the reason I bring this one up is we are seeing this more and more, and there's a concern about whether that flap's going to move her. And again, what was the point? I wanted something long that's not going to force me to land my main body, like little segment in the area where the dissection was. And so sure enough, in this case, I was able to put exactly the right size where I was able to sort of exclude the area where the dissection was completely and get a nice seal and also good flow all the way down that's nice and laminar. And you could, I don't know if you guys saw that little type 2. Why? Because the body was up top, right? The longer the body, the more likely it would go away. And last one I'll show you is this aneurysm that just goes on forever. And how, again, having something that can be put in one spot and gives me a lot of options. Because it's not just about the actual procedure. It was also about the ability to get something that's the right size and that, I can mix and match the bodies and the limbs so I can really decide what outfit I want to put on this guy. Yeah, you know what I'm talking about, right? Yeah? And so here we go. And I really like that. The more weird and complex these aneurysms are, weird and complex for us, not for you guys. I know that means something else to you guys, but on the day-to-day thing, the more you like to have options, because I don't like being told these are two main body choices and this is your limb and this is what we're going to have to lose out on if you do this. And because then I'm thinking, well, I might as well just do this open. I don't want to have Dr. Yilton beat me later on. And so I now have all these options and I can actually do something endo, get a good result, and do it on IFU, which is wonderful. And so I thank TREO for letting us have that on the market. And with that, I'll hand it over to Dr. Arco. Thank you.